I'm Dr. Alicia Cummings, and in this video, we're going to talk about some basic strategies we could use to help address children's incorrect productions of R or Er. And let's first consider when we should start thinking about addressing in treatment. As we've previously discussed, 90% of children who are 5 should be producing the correctly. So it makes sense that we should at least be considering treatment of incorrect R productions as children enter kindergarten. In general, I like to consider providing earlier rather than later treatment. If for no other reason, we want to avoid the development of strongly ingrained bad habits. The longer and more often a motor pattern is produced and producing it incorrectly, it becomes harder to change. So it's easier to change things in younger children. And when we consider our older school-age children who still have speech errors, they're often classified as having an articulation disorder, as there's usually just a few sounds that they have difficulties with. And usually we can think about these children as having a distortion error rather than a substitution or a deletion error. So they have that vocalic or vocalized role or instead of a good rather than substituting a completely incorrect sound for that But there's often more to these school-age kids than you might initially think. Specifically, we can classify our kids into 2 different groups. So some children start producing that distorted as preschoolers, but their speech is overall quite intelligible. And so as a result, these children often do not qualify for therapy using developmental logic, which suggests that maybe we should wait and see what happens to these kids. Maybe they'll outgrow this incorrect And instead, what happens is these kids continue to have this distorted and they come back to us in their later years, 2nd, 3rd, 4th grade, when they're still not producing that R correctly, and we label them as having these persistent errors. But by the time these kids are often eligible for intervention in the schools, they have had several years of practicing these distortion errors, which makes it sometimes really tricky to fix that because they've had so many years of bad practice. And then on the other hand, we had the kids who had multiple speech sound errors as preschoolers. They had all sorts of sounds they had difficulties with, and they were in speech. And these kids tended to have more substitution errors as a full woof or early on. And if they're unable to master that early on, they may initially and eventually transition into producing this distorted error. But these are kids who have residual errors because they've had a history of speech sound error production. And often when we get to them in the school years, this is the last sound that we have to work on. And so the question should be here is whether we should be treating children who have these distorted productions. And I personally would say yes. It's been found by Smith that the W for substitution is quite common in preschoolers, but those distorted productions occur less than 15% of the time. So these are kids, if they're producing distortions, that's not something that's probably going to go away. And maybe we want to address it so that we can eliminate those years of bad habits and we can get them fixed up before they even hit kindergarten and they can just go on their merry way. All right, so generally when I approach treatment of any sound, I use a complexity approach. So what does this mean? So in all of the world's languages, some sounds are considered to be more complex than others. And complex sounds are considered to be more marked than others because they're typically later acquired, phonetically more difficult to produce, and often children are not stimulable for these sounds, meaning if I just ask them to say they can't do it. And often that's due to the articulatory complexity of the sounds, of those certain sounds. And so complexity theory suggests that by training a complex structure that will promote generalization or generalized improvement of simpler linguistically related structures. So by exposing our kids to these higher ordered, more complex elements, these lower or secondary elements often fall into place and generalization will occur. So this means that by working on more complex things, children will learn the simpler things for free in the process. So in treatment then, I will often choose to work on a more developmentally later acquired sound, such as rather than an early developing sound. I might also choose to work on a sound cluster like SL, SL, rather than working on just a single sound such as ul, because by working on the SL, my kids will learn about the ul as well as the S. And the idea is that this complexity approach helps accelerate children's general learning and usually speeds up the treatment process so that we don't have to spend years in treatment. As I said before, my treatment approach usually is to target that bunched R, where we work on pulling the body of the tongue up to the palate rather than using the retroflex R, just because it is a more common production for children. And in terms of thinking about the R, there's not just one R. So if you ever come across a goal written for a child saying that they will produce R with 100% accuracy or something like that, to really realize that there are 32 different variations of also known as allophones. There are 32 allophones of and each one is considered to be a separate and distinct sound. So can occur at the beginning, in the middle, and at the ends of words. It can be combined with other consonants in consonant clusters. For the can occur by itself at the beginning of words, such as run. It can occur after vowels. We also refer to those as rhotic vowels and sounds such as R, air, ear, or ire. Or it can also be in those clusters, such as PR, BR, TR, so on and so forth. And each variation of this can pose a unique challenge because it requires a slightly different tongue position and movement, because the sounds around the affect where that tongue is going to be placed. And so a child may struggle to produce all of these different sounds, or it may only have problems with a few of these variations. And so for this reason, we first have to assess all the different productions to see where the child's errors are. And then we have to identify which ones we need to be working on in treatment, which ones might come in on their own. But for all of these reasons, we need to consider that is a very tricky sound to correct. So most of the children that I work with need some help in learning how to accurately producing that sound. And so that's often where we start. And again, we are going to be emphasizing that palatal and the pharyngeal constriction with the tongue bracing against those back molars. And so we have a series of steps that we usually work through. We first smile. And when you smile, that spreads your tongue and that presses the sides of the tongue against your teeth. So that elicits that tongue bracing. And if we do an E, you can really feel that tongue bracing against the sides of your teeth. And then we talk about getting that tongue up and back. And so we have the E, and then we have to pull that tongue back. And we need to find some facilitative context to help elicit a closer approximation of that So if we have a G or a sh, if you think about G and sh, you can feel where your tongue is. And if you go G, G, sh, you can feel that your tongue doesn't move that much more from the G to the or the sh to the and that gets our tongue, in that high palatal constriction. And to get a little bit more of a pharyngeal constriction, we often use the vowel ah. If you think about ah, you can feel in your throat how that tongue root pulls back just a little bit. So we'll often use a word like ear ga or ear sha, and you can feel how each of those different sounds in that combination helps facilitate, arguably, a correct production of the So that's often where we'll start, is just practicing ers or ears or ear gas until we can get that basic production. Then we can build up from there. Another thing that we often have to address besides just where the tongue is in the mouth is we have to work on tongue-jaw dissociation. And often if you watch a child's production, they often move their tongue by moving their jaw. And this is obviously an immature motor movement that needs to be eliminated so that kids can accurately produce the as well as many other sounds. And so in order to work on this, we often use a bite block of some sort where the child has to hold it in their, hold and bite down on something in their back molars that stops that jaw from moving. And then they have to work only on moving that tongue up and back in a different position so they can learn to move that tongue separately from the jaw. So that's often part of what we have to work on to achieve accurate production. Another thing that often we have to work on is building up children's ability to say the sound. So often they can say but as soon as they start adding it into longer linguistic productions, a single syllable word, a multi-syllable word, they start to break down. And so sometimes we'll use speech chaining as a process to teach them how to continue to produce that correctly as we make the sound linguistically more complex. So we can use either a forward chaining or a backward chaining process. So for example, forward chaining, we might just start with the and then we might practice ray, and then we'll move to rain, and then we'll move to rainbow, and then we'll move to a phrase such as over the rainbow. And we're going to move forward only as the child is able to produce that sound correctly in each of those different contexts. Sometimes it's easier, surprisingly, to work backwards. So we may start at the back of a word. So we might just go and then we might go der, 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 and then we might go under, and then eventually we'll say it's under the bed. So both approaches allow the child to practice at that linguistic level where they can be successful while still challenging them to produce a more complex form. And eventually we can move on to other things. Once our child is able to produce that on command, it's stimulable for them, we may also consider using other approaches. So for example, if the child can produce the but is commonly substituting that w, we might take a more phonologically based approach where we contrast minimal pair words where they begin with and w, and such as rake and wake. And so using these minimal pair words, it encourages the child to think critically about what sounds are in the word that they want to say to ensure that the child is saying the message they want to say. And when they say, I want to wake the leaves, I'll say, you want to wake? And by teaching the child to think about that error, they can sometimes fix it up on their own. And that really is solidifying that learning and will really decrease that error substitution. So as I say, I often take a motor-based approach to my speech treatment because most of my children have difficulties saying their sounds. But even when we use a more phonologically based approach, I do my best to incorporate the principles of motor learning in all of my sessions. And so following these principles helps me best support the kids' learning process. So before beginning an intervention program, we need to first make sure that our child is motivated to learn. So this often includes involving the children and the parents in the process of choosing the correct intervention target and choosing goals that are functionally relevant to the child. We also want to make sure that the child understands the tasks that we want them to do. So we have to use very simple, clear instructions, and I need to provide good models of correct and incorrect productions. And the child needs to understand what is a correct and what is an incorrect production, so they know what they're shooting for in terms of accurate productions. And then we also need to ensure that the child's perceptual abilities are accurate in terms of just general hearing acuity, as well as being able to contrast and hear the difference between an and a W. If they don't hear that difference, we may have to spend some time doing some perceptual tasks, teaching them what is an and what is a W or a W. Okay. So practice is obviously the way to change skilled behavior. And it is our key component to speech treatment. So we need to structure our treatment sessions so that our kids have a lot of opportunities to practice the desired behavior, that is to practice their sounds. We also need to keep in mind sometimes that shorter sessions, occurring more frequently, might be more productive than fewer but longer sessions. And practicing with a variety of practicing with some variety in our productions can lead to greater change than practicing the same way every time. So we'll often change voices. We'll do the zombie voice, we'll do the cheetah voice, and we'll do high pitch and low pitch, and we'll do a variety of activities because the variation helps the children develop a more robust representation of their sound and will ensure that they're able to produce that sound in many different situations and not only in a very specific situation that occurs sometimes in a speech treatment session. We like to eventually randomly present different words to children rather than saying the same sound over and over and over by having to think about this word and then this word and then this word really forces them to think about the representation of that sound as it occurs in different contexts. And it's also important for us to focus on producing the entire sound rather than producing movements that are just associated with part of the sound. So for an we're not just going to practice smiling so that our tongue gets up and hugs the teeth. We're going to practice the movement while producing a sound. So we need to associate movement with actual sound production. And how we provide feedback can also affect children's learning process. So early in the intervention process, we might provide a lot of information about, we might provide what we call knowledge of performance, or KP, where we tell the child specifically what they're doing correctly, what they're doing incorrectly. So this will provide information, put your tongue up, you need to smile, show me all your teeth, don't move your jaw. But once kids are able to produce that sound correctly, we need to change our feedback so that we're focusing on the knowledge of results, or the KR, where the focus is on whether that target was produced correctly or not. So this is when we'll say, great job. Oh, not quite. That was a good try. That was so-so. And we need them to think about that it was correct or not, but then by not providing them with the additional information, they have to, make it, they have to understand how to say that sound, using their own internal representation rather than relying on the therapist to say and tell them what was right and what was wrong. So this will lead to better learning when they have to rely on their own knowledge base rather than taking that external knowledge from the therapist. Initially, we will provide a lot of feedback, but in the end, less feedback can also lead to greater learning because it allows the child to reflect on his production. So we'll say, yes, that was a good job, but then we won't provide feedback. So they had to think about whether that was appropriate or not. And this is also leading the children to learn to self-monitor their own productions. Until children are able to identify whether they said something correctly or incorrectly, they will not progress, in therapy, so that they will not have to be in therapy. They need to self-monitor and be aware of their correct and incorrect productions so that they can move on and get out of therapy. So we need to be encouraging self-monitoring as early as possible in our intervention process. And we also need to think about the delay at which we provide feedback. So if as soon as they say something, we jump in and say, oh, that was right, oh, that was wrong, that doesn't give the child, again, that opportunity to reflect on what's coming from their own body. So we need to give them that time to process and get the feedback from their own bodies to decide whether it's correct or incorrect. So having that delay between when we provide that feedback allows them to think about the auditory, the tactile, the kinesthetic, the proprioceptive feedback that they get from their body so they can maybe make their own changes as needed. So regardless of the type of treatment we use, we often pay very close attention to the words or the stimuli that we use in our treatment approaches. So often we'll use high frequency real words, we'll use academic vocabulary words and or nonsense words. And each type of word serves a different purpose. So our high frequency words are the words kids are going to come across all the time. Whoops, right here, all the time in their daily life. So working on these words in treatment will allow them to use these words in other situations outside of treatment. And so you're like, well, that should be the word we use all the time. But the problem is these are the words that children often develop frozen productions for due to years of bad practice. So these are the words they're commonly saying incorrectly. And these then can be the most difficult ones to change and fix because the kids have such an ingrained habit of how they produce these words. So a way around that is to use nonsense words, because these are words that children have never heard before. And so we usually associate these nonsense words with concepts and meanings as we introduce them in some sort of story, such as this story with the chicken. And by using these nonsense words, the children can focus on the sounds in the word without having those bad experiences that could influence their production. So using these nonsense words allows us to explicitly control the sounds surrounding our target sound. We get to manage and control that context to ensure children get practice in producing their sounds in many different situations. And we can really have some nice progress here by using these nonsense words in treatment. So in addition to our nonsense words, sometimes we use academic vocabulary words in treatment. And these are words you commonly come across in academic texts, but you rarely use in speech. So these are words like region, locate, secure. These are words you read and you know, but they're not words you're commonly talking about, with your 4-year-old, for example. So because of this, academic vocabulary words are often nonsense-like words to young children, and we can use them in treatment in a way similar to the nonsense words. Kids don't have any bad experiences with these words. We can focus on the sound productions of these sounds, and we can move forward fairly nicely. And while you might think these are complicated words for children, they're not necessarily any more difficult or challenging than any other word. For example, region honestly isn't any more difficult to say than rabbit. So just something to think about. And finally, we've published some studies specifically looking at the learning effects of different types of words. Got a couple studies here. And what we found that all 3 types of words, real words, academic vocabulary words, and nonsense words, elicit similar amounts of phonological change in children. So they're all facilitative of phonological change, and it just depends on the child's need, what kind of sound we might be using in treatment.